So as I was saying, those that are at increased risk for refeeding syndrome are patients who have chronic alcoholism, who've been chronically undernourished or malnourished, of either calories and or protein. Again, remember morbidly obese patients. Most morbidly obese patients are malnourished, especially if they've had a recent massive weight loss. Anybody who's been under prolonged fasting, and anybody who has cardiac or cancer cachexia, which is wasting related to cardiac disease or cancer. There are a lot of complications that can occur here. We see things like malabsorption of nutrients. It can worsen things like respiratory distress and heart failure. It can even end up causing things like convulsions, coma, and even death. So this is something that's very serious that you definitely need to be able to identify early on so we don't get to the point where the patient's convulsing, can't breathe, and is dying. So what we're going to do is we're going to monitor labs very closely so we can help identify if a patient has refeeding syndrome occurring. The key things that we're going to monitor, and you're going to need to know this, is potassium, phosphorus, and magnesium. So if you want to do like ppm, if that helps you remember, whatever it helps you remember, potassium, phosphorus, and magnesium serum lab values are going to be monitored very closely in a patient who has who's at risk for refeeding syndrome. And remember from the previous slide, the person who's at increased risk for refeeding syndrome is marasmus patients. So we're definitely a patient who has marasmus. We're going to be watching closely for refeeding syndrome because this can kill them. Also, patients who are getting TPN or total parenteral nutrition are going to be at more risk. Other things we're going to do is if somebody actually has refeeding syndrome or is at high risk for refeeding syndrome is we are going to monitor their fluid balance by getting weights daily as well as doing I's and O's. Daily weighing is going to be the best way for us to monitor fluid. If you end up seeing a weight gain of more than 1 kilogram a week, what do you think is the cause here? It is going to be fluid retention, and we want to avoid this. That is why we need to monitor those weights. Overfeeding can really burden both the kidneys and the liver. All right, so then let's talk about a different thing. This is something we see more in the ICU. It's called multiple organ dysfunction syndrome, or MODS. This occurs more commonly after a trauma or severe burns, infection, or shock. You can see here it's going to, at least 2 organs are going to be involved. You can actually look in your book if you want to see nutritional concerns by system. That is more detailed than I am going to be concerned with. I want you to know that if your patient has multiple organ dysfunction syndrome, they need to have higher levels of calorie and protein because they are in a hypermetabolic state. Any patient who's in a hypermetabolic state is going to need more calories and more protein. This can end up going to organ failure and causing a death in your patient. So again, not identifying the nutritional needs of this patient can kill this person. So I really want to make sure you know what we need to do. The intervention is more calories, more protein. Again, whenever possible, we want to be able to do enteral feeding. What that means is we want to be using the GI tract whenever possible, whether it be from the patient consuming the food themselves or using a nasogastric tube or some sort of feeding tube. All right, surgery. No matter what type of surgery a patient gets, even if it's an uncomplicated minor surgery, elective surgery, like let's say getting a knee replaced, even that patient is going to have an increased calorie needs of at least 5%. The more complicated or more severe the surgery is, the more calories this patient is going to need because they're going to be in an even more hypermetabolic state. Their BMR is going to be higher than someone who than the same patient before they had this surgery. So what are we going to do? Especially if it's an elective surgery, preoperatively, we're going to want to identify anybody who has any malnutrition or any nutritional deficits at least 2 to 3 weeks prior if we have the ability. Now, you might be thinking, well, if this patient came in emergently with after a car accident and has to have surgery to correct fractures, obviously we're not going to be able to do this. But if this is an elective surgery that we are aware of, like for example, even patients who are transplant patients, we know that they're on the transplant list, we don't know when they're going to get the transplant, so we want to keep their nutritional deficits to a minimum. This patient is going to be on a high protein, high carbohydrate diet. Now, if this patient is obese before surgery, obviously we want them to lose weight because that'll be easier for them. If we're using general anesthesia, they will need to be nothing by mouth or NPO at least 4 to 8 hours before, depending on the type of surgery as well as the procedures at the facility. After surgery or post-operatively, we want to progress that diet as soon as possible. Remember we talked about going from clear liquids to full liquids to soft bland to regular diet very quickly. We're going to do things like assess for bowel sounds, that they're passing gas, they're passing the bowels, and they're tolerating their diet. Those are going to be signs that we can progress the diet further. All right, burns. Burns are very complex. Patient is at high risk for lots of different things. The first thing you need to know is you need to know what type of burn there is. For example, it could be electrical, thermal, chemical, or radioactive. The next thing you want to know is you want to know the degree. Is it a first degree, which would be only the epidermis? For example, like when you get a sunburn, a simple sunburn could be a first degree. Its second degree goes down to the dermis, and third degree goes down to the subcutaneous tissue. You also want to know the percent of body surface involved. We use this thing called the rule of nines. This is the degree in which the metabolic rate increases is directly related to the body surface area burned. So this patient may actually end up being in this hypermetabolic state for weeks. Like I said, we are not going to focus on pain management, wound care, or infection control in this class. Burn patients are particularly susceptible to those, as well as sepsis. If your burn patient becomes septic, those calorie and protein needs are going to be even higher. So you already have a patient who's in a hypermetabolic state. Now we have something that happens to them and puts them even in a higher hypermetabolic state. These patients might need things like as much as 4,000 to 5,000 calories in a day. The amount of fluid that this patient needs is going to be based on their age, their weight, the extent of the burn. We like to do lots of high fluids for nutritionally because fluids are going to help the kidney eliminate waste products. So we actually do this thing called fluid resuscitation. We want to make sure that we're meeting their nutritional needs as well. So that's why we're going to do a high calorie, high protein. We're going to use carbohydrates and fat to make sure that we're not using protein for calories, but instead we're using protein to build new skin tissue. Let's see. I have seen patients that need as many as 8,000 calories a day, so definitely high calorie. The other thing too, reason why it's a high protein is you're going to lose protein through your urine, through the wound, and again, you need more protein, so these are all reasons why we need lots of protein. So how can we get this patient to get lots of protein? We can do more things like small frequent meals. We're going to be doing those calorie counts where we're documenting in percentages and ounces how much the person is eating so we can show that we are meeting the patient's need. We're going to have the patient eat themselves, like orally, as much as possible, but we can again use enteral nutrition, which is tube feeding, or possibly TPN, which is through intravenous feeding. Another very important thing to do is to monitor and make sure that these patients are start feeding as soon as they get rehydrated. Very early enteral feeding, we're talking like 4 to 12 hours within admission, has been showed to decrease this hypercatabolic response, which is the response by the body to start breaking down their muscles for calories. We're going to see also that they're not going to lose as much weight, those patients that start eating within 4 to 12 hours of admission with this burn, and also their length of stay is going to be shortened. Again, we may need to use tube feeding into the small intestine to do this because some patients actually, peristalsis actually stops in some patients, so we need to actually go into the small intestine for that tube feeding. All right, here, this is something that you can work on your own. And we will then come to class with these already answered, and then we can discuss this as a group. As well as we will go through these questions which you already have in class as well as a review. Have a great day.